Today we're focusing on hypovolemic shock, the most common type of shock. This condition is defined by a decrease in intravascular volume. What is hypovolemic shock? Body fluid is distributed between the intracellular and extracellular compartments. The intracellular space holds about 2/3 of total body water. The extracellular space is divided into intravascular fluid inside blood vessels and interstitial fluid surrounding the tissues. The interstitial space normally contains 3 to 4 times the volume of intravascular fluid. Hypovolemic shock occurs when intravascular volume drops by 15 to 30%. In a 70 kilogram or 154 pound person, this equals approximately 750 to 1,500 milliliters of blood loss. Pathophysiology. Hypovolemic shock can result from external fluid losses such as trauma, surgery, vomiting, diarrhea, diuresis, hemorrhage, or from internal fluid shifts such as severe dehydration, burns, ascites, peritonitis, necrotizing pancreatitis, diabetic ketoacidosis, diabetes insipidus. The sequence of events begins with reduced intravascular volume. This lowers venous return to the heart, decreases ventricular filling, and reduces stroke volume and cardiac output. As cardiac output falls, blood pressure drops, and tissue perfusion becomes inadequate. Medical management. The major goals are to 1. Restore intravascular volume. 2. Redistribute fluid volume. 3. Correct the underlying cause of fluid loss. These goals are often addressed simultaneously. Treating the cause. If the patient is hemorrhaging, apply pressure or perform surgery to stop bleeding. If vomiting or diarrhea are the cause, give antiemetic or antidiarrheal medications. In older adults, dehydration may be the primary cause and requires prompt fluid replacement. Fluid and blood replacement. Fluid replacement is a top priority. At least 2 large-gauge intravenous lines are inserted. If IV access is not possible, an intraosseous line may be placed in the sternum, tibia, or humerus. Multiple lines allow simultaneous infusion of fluids, medications, and blood products. Crystalloids like lactated ringers and normal saline are first line. If hypovolemia is due to blood loss, the 3-to-1 rule applies. For every 1 milliliter of blood lost, 3 milliliters of crystalloid solution are given. Colloids such as albumin may also be used, though starches and dextran are avoided because they impair clotting. Blood products, plasma, packed red blood cells, and platelets are used when hemorrhage is the cause. Massive transfusion protocols recommend a 1-to-1-to-1 ratio of plasma, platelets, and packed red blood cells. Redistribution of fluids. Positioning can assist with fluid distribution. Passive leg raise, or PLR, can help evaluate fluid responsiveness by increasing venous return and blood pressure. The Trendelenburg position is not recommended because it impairs breathing and does not improve cardiac output. Pharmacologic therapy. If fluid therapy is not enough, vasoactive medications may be given to prevent cardiac failure. Medications may also target the cause of dehydration, such as insulin for hyperglycemia, desmopressin for diabetes insipidus, or antidiarrheals and antiemetics for gastrointestinal losses. Nursing management. Primary prevention is key. Monitor at-risk patients for fluid deficits and intervene early. General responsibilities include safely administering fluids and medications, using IV pumps for accurate delivery, monitoring for complications, and reporting promptly. Administering blood and fluids safely. Obtain blood specimens, a baseline complete blood count, and type and cross-match quickly. Monitor closely during transfusion for complications. Transfusion-associated circulatory overload, or TACO. Transfusion-related acute lung injury, or TRALI, characterized by pulmonary edema, hypoxemia, respiratory distress, and infiltrates within hours of transfusion. Older adults and patients with cardiac disease are at higher risk for these complications. Excessive fluid resuscitation may also cause abdominal compartment syndrome. Early signs include difficulty breathing and decreased urine output. Other monitoring includes vital signs, heart rate, blood pressure, and pulse pressure, central venous pressure, arterial blood gases and lactate levels, hemoglobin, hematocrit, and coagulation studies, jugular venous pressure. IV fluids may need to be warmed to prevent hypothermia during rapid infusion. Other measures. Oxygen therapy is always provided to maximize hemoglobin oxygen delivery. Patients may feel anxious about masks or cannulas, so frequent explanations help reduce fear. The nurse also focuses on patient safety and comfort throughout resuscitation. Final takeaway: hypovolemic shock is the most common type of shock and can be deadly if not treated promptly. Remember, a 15 to 30% drop in intravascular volume can trigger shock. Always identify and treat the underlying cause. Use crystalloids and, when needed, blood products to restore volume. Follow safe transfusion practices and monitor for complications. Nurses play a critical role in early detection, safe fluid and blood administration, and supporting patients and families through this crisis.